Conference will now be recorded. This conference will now be recorded.
So I handed out this same thing. It's just a good reminder. Probably going to be another test question over it. We're going to go over it again more tonight. So I sent it also in an email to Austin. So very good, very good.
Very
Just a
good.
reminder. Are you guys excited? Yes. Me too.
For a test?
For no
No,
test.
she said
Oh.
no test.
For no test.
Sorry, I'm tech.
Or we would not be like that. We wouldn't be like, no test, and then surprise test. We would not do that. That's the big-
It would be funny though.
It would be funny.
No, you say it's gonna merge them together.
Not for y'all, yeah, not for y'all. Okay, so, respiration and artificial ventilation, this is chapter 10. Again, like Chad said, a lot of review. So a lot of it's just gonna be reviewed, from what you already learned in A&P. We're gonna sprinkle some new things in there and just add on, right? Because that's all EMS is, just building blocks. So, our objectives, we're gonna know the difference between inhalation and exhalation. We're going to review the mechanics of positive pressure ventilation and just ventilation in itself. So the differences in like how they act on the human body. We're going to review the dangers of oxygen administration. You guys get to see my first real soapbox tonight. I mean, you already saw the Narcan one, but Chaz kind of took over, so you'll see my soapbox. And then describe the differences in adult ventilation and pediatric ventilation. We're going to go over tidal volumes, what's normal, how to calculate what's normal, all that fun stuff. All right, so the mechanics of breathing, as we know from our little model here, how do we take a breath in? What kind of pressure system is inside of our lungs? It is negative, right? Someone just texted in the chat.
Mm-hmm. Got that crazy wrong.
Because it acts in the lungs.
Vacuum or whatever, or like-
Oh,
I picked my second guess one, but I got it wrong.
okay. Was it like talking about the diaphragm?
Yeah, what happens when your diaphragm, like, when you breathe in or whatever, your diaphragm is like.
Oh, yeah. Yeah, so when you breathe in, diaphragm goes down, and then as it relaxes, it goes back up. It's backwards than what you would think. They just did that to confuse you.
It works.
So, it worked. All right, so ventilation is the process of moving air in and out. So the two things that really confused me when I was going through EMT class was like ventilation and oxygenation, because in my brain, those were the same things. But there is a big difference between ventilation and oxygenation. So diaphragm comes down while we inhale. As we exhale, it comes back up. And then our intercostal muscles, they also work. So in our little picture here, our intercostal muscles pull up. Same thing our diaphragm does as we breathe. They both go up. And as we relax, it comes back down. Right? So inhalation is an active process. There's actively your diaphragm moving down. It's an active process. So everything contracts, it comes down, and that negative pressure pulls the air into the lungs, just like with our little model. As it comes down, actively pulling it down. And then obviously as we take it in inhalation, as you guys can tell just by sitting there taking a breath in, our chest size is going to increase, right? All right, so exhalation, this is our passive process. So inhalation is active, exhalation is passive. So exhale, if you exhale, you breathe out, right? So then our chest size decreases, and then that positive pressure pushes the air out of the lungs because that diaphragm's coming back up and pushing it out. So inhalation is what? Active. Exhalation? Passive. Very good. Good to remember that. All right, so important volumes to know, as you can see on your little sheet that I handed out, the tidal volume is the amount of air moved in one breath. What's the average tidal volume for an adult? 500. Good. How do we figure it out if, like, their ideal body weight? Do you remember? We wrote it on the board the other day.
Their height.
It's a certain amount of milliliters per kilogram. So it's either 4, 6, or 8 milliliters per kilogram. That's based on their ideal body weight. So that's across the board. That's pediatrics and adults. So if we have an ideal body weight, and that's all based off of our height, that's how you figure out how much tidal volume they're supposed to be taking in one breath. And then our minute volume is over the whole minute, right? So it's the respiratory rate times the tidal volume is our minute volume. Right? Got it? Review. Was there a question on y'all's last test that was the multiplication? Is that what the multiplication
The answers, I would just looked at the answers and went back to the math.
Really? I do that same thing. I'm like, oh, math, and then I freak out.
Like if you know that it's the total volume times the breathing rate, the options were like 350 milliliters, 50 milliliters, some, and then 2,000. And it was obviously 1,000.
All right, so ventilation. It is the movement of air in and out of the lungs. Okay, so as it moves in, it moves to the alveoli for gas exchange. What surrounds our alveoli? Capillaries, right? So that blood gets real close to our alveoli by capillaries, and that gas exchange happens, right? So diffusion's on the next slide. But not all your air reaches the alveoli. What is that called? Dead air, right? How much is that on average? 100 to 150. I think those folks said it's 150. So alveolar ventilation is the amount of air that actually reaches that alveoli. So you have your dead space, which kind of just chills in there, and then the alveoli. The alveolar ventilation is how much actually gets into the alveoli. So if you're not breathing, if you're not taking deep breaths, if someone's taking really shallow breaths, that can cause an effect in their alveolar ventilation, right? So a perfect example of this is like if somebody breaks their ribs, a lot of times they take really shallow breaths because it hurts, right? So if someone's breathing really shallow, it can change how much is actually getting diffused into the blood. Also, same kind of idea, like if you have a really fast heart rate, you're not getting as much blood out, right? So same kind of idea with your respirations. If you have really, really fast respirations, chances are you're not getting a good amount of oxygen in, right? If I'm breathing it, like that little kiddo that was breathing it 90 times a minute, the last one, like he probably wasn't getting a lot of good oxygen, right? I think I have a couple little videos in here showing stuff if I remember. So here's our alveoli. We have the end of the bronchial tubes up here. We have our inflated and ventilated as air moves in and out. And then those pulmonary capillaries bring that blood close to the sac so they can have that onloading of oxygen. What on our red blood cells carry the oxygen? Anyone remember? Hemoglobin? It's the hemoglobin. So the hemoglobin on our red blood cells picks up that oxygen. It's like, you come with me. So it can go oxygenate the rest of your body. So oxygen moves into the blood, and then carbon dioxide, which is our body's waste product of our metabolism, it gets breathed out. Right? So buildup of carbon dioxide, bad thing. Low oxygen, bad thing. We want all this to be happy and balanced, right? All right, so diffusion is how that gas gets from one area to another. So it's the movement of gases of a high area of concentration to an area of lower concentration. Our bodies are trying to get everything to equal out. So that's where that oxygen, there's a lot of oxygen in that alveoli, and it moves into the blood, which doesn't have a lot of oxygen. And that process is diffusion. That's how that works. So pulmonary respiration is that diffusion of oxygen onto our blood from our alveoli. It happens in our lungs, right? So pulmon, meaning lungs. This happens in our lungs. So then we have cellular respiration. So that happens at the cellular level, right? So the oxygen gets loaded onto our red blood cells. It gets carried out to our cells in our body, and then that's where cellular respiration happens. So pulmonary lungs, cellular at the cellular level. That's a tongue twister. Or Marcus, all you've heard is lectures today. He's always bringing stuff. It's what paramedic school does to you.
That's a lot of lecture.
Mm-hmm.
Looks exhausting. Just as opposed to that stuff that.
Those come and go. So here's a close-up of pulmonary respiration. So there's our ravioles, right? That oxygen. There's a high level of oxygen out here, a high level of CO in the vasculature. So that diffusion happens, that oxygen comes back in, gets loaded, and that CO2 goes out, and we breathe it out. So we have ways of measuring that CO2. Does anybody know what we use to measure the CO2? Got a little orange cap on. We talked about it a little bit. I was just gonna see who. There is a T in it. Our little end-tidal CO2 monitor. So end-tidal, what we're looking for, and we'll learn normal levels. I think I have one.
It's just dry now.
Didn't even spit it.
What'd you say?
I would not.
What'd you say?
Marcus started it.
What'd you say?
I didn't say anything.
That's what he did.
It was a physical.
He didn't even do that.
Ridiculous. All right, so here's our cellular respiration. Mostly this bottom part of this where it says red blood cells. So red blood cells go out to our cells. That oxygen's offloaded onto our cells where we need it to be. And then that carbon dioxide's loaded on and it gets breathed out. I was just gonna ask a question. Oh, what happens if there's a problem and it's cut off? What is that called? It can be mechanical. It can be like a vein problem, huh? It could, respiratory failure can cause it. It's that big word that's been like highlighted in every single PowerPoint that we've done pretty much. Shock, hypoperfusion. So if there's any reason that this oxygen can't be exchanged anywhere in this system, it leads to hypoperfusion or shock. So air goes in and out, blood goes round and round, right? So they need to work happy together, right? So this is our cardiopulmonary, so heart and lung system. And if there is happy and everything is working as it should, right? We have something called what? Homeostasis, yes. But specifically, everything's going around like it should. So you have air going in and out, which is called what? Huh?
Perfusion.
Okay, so you have ventilation.
Is that the VQ map?
It is.
Mhm.
And then your perfusion, which is your Q. I'm going to write it like this every time. It's perfusion. Why they gave it a Q, I have no idea.
Oh,
So when everything's really happy and everything's working as it should, it's called a VQ or a ventilation perfusion match, right? As soon as something goes wrong, it's called a VQ mismatch. So we're aiming to obtain a VQ match in all of our patients. That's really what it all comes down to. So if the respiratory system fails, it can cause a VQ mismatch. If the perfusion system, the heart system, the veins, the vasculature, if that fails, it can also cause a VQ mismatch. So we've got to figure out what the problem is. What is causing this patient to have a VQ mismatch? So mechanical failures of the cardiopulmonary system. Here's some examples, right? So obviously a giant hole in somebody's chest. That's a mechanical problem, right? So you think that's going to be a ventilation problem or a cardiovascular problem? Or both? It'd be both.
I can't see what's correct.
Oh, hydrophilic ventilation. I'll write on the whiteboard. Okay, so yeah, they're bleeding out usually into their chest, and then their lung is also usually affected, right? If there's a giant hole in their chest. What about something like this on the left-hand side with the red circle? It can be, yeah. So it can be like a cardiac tamponade. You see that bruising on someone's chest, they took a hit, right? So it can be a heart problem. It can be a lung problem. Does it cause like a pulmonary, like a pneumothorax? Is it causing bleeding into their chest? So that could be both. What about a spinal cord injury?
It affects the nervous system.
Yeah, it affects the nerves that allow our diaphragm to move, right? So that'd be a lung problem. And then we have something like asthma. So the bronchioles constrict, and then that allows for, or it doesn't allow that air to get in and out of the lungs, right? So that's a ventilation problem. So ventilation problem, probably perfusion problem, maybe ventilation, maybe both, ventilation problem. So just know that they can all be affected, right? All right, so low oxygen levels outside can obviously cause how much oxygen you're breathing in. So somebody that has like carbon monoxide poisoning, if they're like stuck in a house fire, or if they put the hose in their car and they're trying to commit suicide, suffocation, that's low oxygen levels in the outside air, right? Obviously that's going to affect how much oxygen you're able to breathe in.
That stuff sticks to your receptors also.
Yeah. Yeah. It does. Yeah. So it has they call it a higher affinity. So your hemoglobin likes carbon monoxide more than it likes oxygen. So if you're breathing in carbon monoxide, it's like, oh heck yeah, I'm taking this guy with me instead of the oxygen. And so, and that's where it can get tricky, because your pulse ox that you put on someone's finger will actually read like 100%. But it's actually just reading the carbon monoxide. So always keep a high index of suspicion, especially with like your like house fires and stuff like that, because it'll tell you one thing, but you know that it's off. So so diffusion problems caused by alveoli that do not work can also cause a problem, right? So if there's a buildup of fluid in your raviolis, or if those alveoli are like completely collapsed, that can cause a problem. And then circulation issues, right? So any kind of shock can cause a VQ mismatch, right? So we have our distributive shock, like sepsis or anaphylaxis, that can cause this low hemoglobin. If you don't have enough hemoglobin to carry oxygen, you're going to have a problem getting oxygen to your cells. And then obviously if you're bleeding out, that also has hemoglobin in it, so you're losing all of the stuff that you need to carry all the goods. What did they say in the chat? I heard it go ding. Oh, I thought you were looking at it.
Oh,
Oh, okay. You take a look.
I can pull it up.
Okay. Very good, very good. Okay, so this isn't really in your book, the types of hypoxia, but I do want to cover it because it kind of gives you guys an idea of like more than just not having enough oxygen in the air can cause problems. So there's types of hypoxia. There's 4 different types of hypoxia. So the first one is like a lung problem or an outside air problem. So it's called hypoxemic hypoxia. Like I said, you don't have to memorize all these words, but just to put it into perspective that multiple things can cause that hypoxia that can lead your patient to go into shock. So if you ever see like a low oxygen saturation on a patient, don't always just assume it's because they're not breathing in enough oxygen, right? So you have hypoxemic, that's a lung problem. Can you keep it down
Don't just bring it down with
a little bit? So they have low. I can't hear. I can't talk. That's just how that works. Okay, good. All right, so lack of oxygen in the atmosphere. This is your hypoxemic. This is a lung breathing in and out problem. You have your hypemic hypoxia, so this is a blood problem. So this is like your anemia. You don't have enough hemoglobin in your system. You have short red blood cells. You're bleeding out, something like that can cause like a hypemic hypoxia. Another thing is your CO poisoning falls under the hypemic hypoxia because that hemoglobin is affected because there's too much CO or carbon monoxide on your hemoglobin. So that's like a blood problem. Next is your stagnant hypoxia. So like if your heart's not breathing, your blood becomes stagnant, right? So that is a perfusion problem. Your heart's not beating as it should. So that's your stagnant hypoxia. You can be blowing freaking so much oxygen into this patient's face and their oxygen saturation isn't going to go up because you're not fixing the core of the problem. And then you have your histotoxic hypoxia. So this little globe thing is supposed to represent a cell. I couldn't find a little emoji that looked like a cell. So histotoxic hypoxia. This is like your hemoglobin is closed. So something like cyanide makes it to where your hemoglobin just can't offload and onload oxygen like it should. So it's a problem with the actual cell. Does that make sense? Okay. So just know, basically everything I want you to get out of this is it's not always an oxygen in the air problem. Right? Lots of types of hypoxia.
What would you do with somebody with the carbon monoxide?
You oxygen like overload them. So you're trying.
Or just over a lot of oxygen?
So if they're breathing on their own, you're putting a crap ton of oxygen on them. A lot of times we use CPAP. The best fix for CO poisoning, if their CO levels are above like 20, I think it's like 25, they'll check their CO levels, but is actually something called a hyperbaric chamber. So we use hyperbaric. We don't have any around here. I think the closest one's probably Reno.
I live in Elko.
Yeah.
Do they
it's
have
not
one?
emergent.
Yeah.
They technically have one in Elko, but it's a non-emergent hyperbaric chamber. So,
Like
none of that
NRH.
happens.
In NRH, we use it. We have like some relationship with them to use it, but
Yeah, that's the
So-
closest, technically the closest emergent.
Yeah, which really sucks. But yeah, so you're just trying to put so much oxygen. You're trying to wash that CO out, and you're just trying to load them up on as much oxygen as you can. And if it gets to a point where they're altered, like they're not able to maintain their own airway, that's where you're going to be bagging them. And you're bagging them with 100% oxygen anyway. So just try to like over oxygenate basically, because you're trying to get that CO out.
They
but-
have pulse oxes that you can use to monitor CO as well. I mean, you need like blood gases to get like super accurate numbers. But they have pulse oxes that you can use that have like a CO monitor on them.
Yeah, so if you ever if you have a CO monitor, our monitors can do it, and you'll see CO pop up right under the SpO2. You want it less than 7. That's normal for you guys, like if you're on a call. So if you put that on somebody and it's reading like 28 or 38, like that's a bad day. They need a lot of oxygen. All right, so hypercapnia is high levels of CO2. So we've been talking about carbon monoxide. So we're talking about carbon dioxide, right? So this is our byproduct of our metabolism. Whenever our cells metabolize, they let go of that acid, and then we breathe it out as CO2. Our normal end tidal, so end tidal is that little thing that we can measure, is 35 to 45. So whenever we talk about like somebody that's not breathing at all, they get a buildup of that end tidal, right? So high end tidal levels, they will also go crazy. So this is part of our soapbox with the Narcan is like if someone's not breathing because they're overdosing, not only is their oxygen levels going down, but their end tidal levels are going way high because they're not breathing off that acid. And so you get a combination of the two. So that's why we ventilate our patients before we slam them with Narcan. That's not my soapbox. It's coming. All right, so respiration, our brain obviously needs a steady supply of oxygen to stay happy, and so do our body cells. So you need to evaluate how well somebody is oxygenating. So we have ventilation, which is the movement of air in and out. Oxygenation is at that cellular level. Is that oxygen getting where it needs to go? You can give, like somebody that's in cardiac arrest, you can put a non-rebreather on their face and blow oxygen in their face. But if they're not physically moving that air in and out, it's not doing anything for them, right? So same thing, if that oxygen is not getting to the cells where it needs to go, it can cause a lot of problems. All right, so inadequate breathing. What's our normal respiratory rate? This kind of comes later, but 12 to 20, right? So whenever we're looking for if somebody has inadequate breathing or not, we're looking at not only the rate, so we want it to be between 12 and 20, but we're also looking at the quality. So how deep of breaths are they taking? Are they taking really shallow breaths? Are they taking really, really deep breaths? Are they not breathing at all? So we're looking for inadequate breathing. This is where we look, listen, and feel, right? So in the cardiopulmonary system, we have those little chemoreceptors that just hang out, and they tell our brain, like, you need to breathe more or you need to breathe less. So that can stimulate your respiratory system to breathe more rapidly. So there's a few things, not only metabolically, that can cause that, like a DKA, like a really high blood sugar, can cause somebody to breathe really fast. But you can also have, like, even something as simple as anxiety can cause it. So any kind of like sympathetic tone, like that fight or flight response that goes off, it can cause your respiratory system to go more quickly.
Speaking of anxiety, until you get a good solid amount of experience under your belt, don't write anybody off as having anxiety. There are so many new providers that will go out to somebody and they're like, oh, they're just anxious. You don't know what anxious looks like compared to other things. We've had 30-year-olds die on us from like pulmonary embolus that somebody that didn't know would have walked in and be like, oh, you're just anxious, like you just need to breathe this medicine better, like calm down, you're fine, like just breathe this stuff and then freaking die. So that's why we're on the topic of anxiety. Understand anxiety is a word that everybody likes to throw around, but don't do that. You go away and get yourself in trouble.
And anxiety is a symptom of a lot of things. So strokes, pulmonary embolisms, heart attacks, anemia, that can be a sign of anemia. Like your body is like, something's wrong with me. And so it shows outwardly as anxiety, but a lot of times there's actually something going on inside. So like he said, don't be that guy. So inadequate breathing occurs whenever there's a challenge that's too great for your body's compensatory mechanism. So our bodies are going to try and save us, right? So you have something going on, your body's going to be like, hey, I'm going to try and fix you. So that's our part of our compensatory mechanisms. So respiratory rate, heart rate increase. As soon as that gets too much for our body to handle, our bodies start to get tired. And we're going to talk about the progressions of like respiratory failure to respiratory rest, that kind of thing. So signs and symptoms that you're going to look for. I already talked about this. Look at the rate and depth of breathing. I was just going to say something else, but it completely left my brain. I'm sure it'll come back.
So when you guys go to like a third person that's having a hard time breathing, you guys just take off the shirt? Or just start looking at the breathing, or you just figure it out over time?
So
like, can you see through their clothes enough to see if their depth is good enough?
yeah, so usually for adults it's a lot easier. We're going to try and strip them down anyway because we need to get to 12 lead on them. So yes, we'll eventually take their shirt off. But if I walk in and like Chaz is in a hoodie right now and he's bent over like this, like struggling to breathe, you're going to see, especially in adults. In kids, immediately just take their shirt off. But adults, you kind of got a little bit more visual cues because they'll show you when they're having trouble breathing. Yeah.
Then with the intercostal muscles, when they're like going really crazy, is that because the diaphragm's not working properly, or is that just because they're
using both the diaphragmatic breathing.
It could be either. So you can have where like their diaphragm's not talking to their like their spine for like a spinal issue, and their intercostal muscles are trying to take over. But sometimes they're just working so hard, their diaphragm's still working, but they're just having such a hard time getting that air in and out. You'll still see that intercostal muscle use. So it kind of depends on like what led up to that moment. So did they fall? Did they dive headfirst into a shallow swimming pool? You know, or did they, you know, were running outside and they can't breathe? What kind of thing are you looking at that like led up to that? 'Cause like especially like your chronic COPDers, they're always using their intercostal muscles. They're always struggling to breathe. So just kind of like read the room a little bit, you know, like don't just walk in and be like your diaphragm's not working. But if they're laying on a freaking sidewalk because they fell, like okay, your diaphragm might not be working. So it could be either or. It's kind of hard to tell. Like it's situation dependent, right? That's a good question though. All right, so here's just a bigger picture of the other picture that was on the other slide. So here's where our chemoreceptors live. The medulla oblongata. It measures our pH. I swear to God, if that freaking thing says hypoxic drive, I'm throwing something at you. I knew it. We haven't gotten to that slide yet. I'm gonna fight you.
waiting.
I knew it. I seen the shitty grin on your face when you walked in. All right, so then we have our carotid bodies. So our carotids, right? So it measures pH, oxygen concentration, CO2 concentration. And then we have some that live in our aortic bodies. So they measure our oxygen and our CO2. So all of this talks together, and then your brain's like, breathe more or breathe less. It's always just constantly taking little samples of your blood. All right, so here's the progression, right? So usually patients start out in a respiratory distress. So the words respiratory distress means that their compensation mechanisms are working. So what we're looking for is they're having a hard time breathing, but they still have normal mental status. They're still talking to you. They're able to do what they've always been able to do. Like I'm talking to you now, or whatever is normal for that patient. Their skin color might change a little bit, but you're not going to see like a huge drastic change. Like sometimes you'll see some redness, some like flushing. And then their pulse ox, it's going to be a little bit low. Sometimes it can be normal and they can still be saying like, I'm having trouble breathing. That all falls under the respiratory distress category. So their mentation is normal. They're talking to you. That, if it's not corrected, leads to a respiratory failure. So what our definition of respiratory failure is a lot of the same stuff that you see in respiratory distress, the shortness of breath. This is where your compensation stops working. Your body is working so hard to breathe that it's starting to go down, right? So the deciding factor, whether it's respiratory distress or respiratory failure, is their mental status. If they can no longer follow commands, if they're completely unconscious, any kind of altered mental status. That's such an umbrella term, but altered mental status is what puts them into respiratory failure. So you think about like somebody that has like really bad asthma or really bad COPD and they're having a hard time breathing. A lot of times these patients can wait like days to call us. So they're like, yeah, it's bad. I'm going to call them. And once we get there, you'll notice somebody that's been breathing that hard for that many days, they're going to be tired. Their whole body internally is running a marathon. So they're going to start to do like this number and they're going to like possibly be altered. So they're leaning more towards the respiratory failure side. Now next is respiratory arrest. So respiratory arrest, if respiratory failure is not corrected, they're just going to stop breathing. Their body is tired. Like we said, they've been working a long time. Internally, their body is running a marathon. So apnea, what is that? Yeah, what does apnea mean? Not breathing at all. No breaths. No breaths. Apnea is no respirations. And then respiratory dysfunction. So sometimes that's where you kind of see like your agonal respirations or somebody just breathing like nothing to sustain life. Like their breathing is not sustaining any kind of oxygenation or ventilation at all. And then after respiratory arrest, what comes next?
Death.
Death. So this needs to be corrected. If you recognize it early while it's in the respiratory distress phase, sometimes you can turn them around. They don't ever have to go into respiratory failure. But just know if they're in a position of respiratory arrest, getting them back is going to take a little bit more work. A little bit more.
These are very, very important in distinguishment because this will come up a lot. When we start doing scenarios, when we take tests, the differentiation between these things is important. Knowing that the altered mental status is a differentiating factor between distress and failure is very important. You're going to see that again. I don't remember if it's on our test. I think it might be. I don't know. But you will 100% see that again. So be able to differentiate between these things because I promise you're going to see it a lot.
Just
Using those two.
these two.
Yeah, and that's what happens.
Failure and arrest, yeah.
Failure and arrest, yeah. So,
People freaking confuse the crap out of these three things. So just understand, arrest, they're done. They're tapped out, body's tired.
they're breathing less than 8 times a minute.
Yeah, they're with Jesus. Okay. Altered mental status is failure. And then distress, they're struggling, but they're still doing their thing. Differentiate those, understand what makes them different.
And it's a ladder. They have to be here to get here, right? So respiratory arrest is still going to have altered mental status because it's a buildup of problems. So it gets from respiratory failure to respiratory arrest. If they're in respiratory arrest, they are breathing less than 8 times a minute. It's not sustainable for life. 8 to 0.
And this same thing happens with overdoses. It's the same kind of progression. They start breathing on their own, they start overdosing, their breathing will accelerate for a second, and then it starts declining, they get altered, they start declining more, they stop breathing, and then that's how they end up in. The same ladder. All of these breathing things can go into the same ladder, but just know what differentiates these different segments.
And we'll practice. There's a few slides at the end of this talk where we can kind of put things into perspective as to what we're doing. All right, number 1, determine if the patient is breathing. You walk into their house and say, hey, how are you doing today? And they talk to you back, they're breathing. If you walk in and they're completely unconscious, that's part of our feel for a pulse, check for breathing thing, right? So number 1, determine if they are breathing. So I think our next chapter, chapter 11, is where we start getting into those sheets. So this is the A part of that ABC assessment, right? So we're determining if they're breathing. Now, is their breathing adequate? Because you can have someone that's breathing 6 times a minute. Yes, they're breathing, but is that going to sustain their life? Nobody is going to breathe 6 times a minute and stay that way for a long time. So this is where we look at, especially with adults, like we were talking about, like check their posture. So high schoolers, they love to teach high schoolers to put their arms above their head whenever they can't breathe. That's not effective. You're giving them less, you're pulling everything up, giving them less space. So tripoding really is better for their breathing if you're struggling, but we just commonly do that anyways. Like that's a normal response. When you can't breathe, you're going to go like this. Your patients are going to do it too. If you walk in and they're hunched over, this is called what? Tripod. Good. So tripod position is a huge indicator that something's going wrong. What is this called?
Cyanosis.
Good. Yeah, cyanosis. So they're blue. Why is it blue?
Lack of oxygen.
Yes, lack of oxygen. Hypoxia can cause cyanosis. Good. And are we always just going to see it on the fingertips? That's the crap. The crap that we see.
Like any dependent part of the bodies, right?
Yeah, so peripherals. So lips, tips of the nose, nail beds, toes. In kiddos, when it gets really bad, they'll be centrally cyanotic, so like their torso will be blue. But usually it starts out with like the fingers, nose, toes. So if there are any signs of inadequate breathing, we want to fix that first. The only The only
Caveat. to that
caveat, that's what I was looking for.
Is bleeding.
Yes. Yes.
You stop bleeding before you deal with everything else. Everything that you're gonna learn from here on out is ABCs, except for when it comes to bleeding. Then it's CAB. You deal with the circulation issue and then go to airway and breathing. So we'll get into that in trauma. So if you get there and they're freaking shot and they're like, oh, I can't breathe. Well, stop this bleeding real quick and then we'll deal with your breathing.
Yeah.
But this is all airway, breathing, circulation.
Even if you go on someone that's like cardiac arrest, they were shot in the leg and they're bleeding out of their leg, you stop that bleeding and then you fix the problem, right? Yeah, maybe I'll confess it's your first trauma call.
I'll break my ankle. I'm going home.
I don't know who's coming in for you.
Huh?
I don't know who's coming in for you.
Anybody want to work?
You know, put you on a roster.
What? I can golf with a broken leg. That's all I've been doing in a wheelchair the other day.
It'll be on a knee scooter, it'll be okay. Yeah, that grass is.
Yeah, I might not be as bad. But, you know.
Right. All right, so some causes, these aren't all the causes, some causes of inadequate breathing. There's some things that you could kind of knock off your differentials. So differentials are problems that you, like the list of things you think could be wrong with the patient. So we call them differential diagnosis. I know y'all aren't allowed to diagnose, but there's a whole PowerPoint and a whole chapter in this book that's like diagnosis, and you guys get to diagnose, but then you can't diagnose, so it's kind of like a twofer. But when I say differentials, that's just a list that you make in your head of like what is going on with this patient. So, some things to keep on your list.
If we're talking with like the doctor, and you have someone in the ambulance, aren't you technically diagnosing, when you're explaining to the doctor what's going on with them?
Technically, yes.
But you're not diagnosing.
Right. So by definition, the word
EMS.
diagnosis.
You're like, you're gonna diagnose this patient, you're gonna give them all these medications, but you better not diagnose them.
Yeah.
You're like,
They like to use
all
the
right,
word
don't freak me.
field diagnosis.
They just add an extra word in there to make it feel special,
Yeah,
I
it's
guess.
a field diagnosis. You're like, his leg's chopped off. You can't diagnose the leg being chopped off. Or their arms like asking you a bunch of, like, you know, when someone breaks their arm, it looks like a question mark, you know? Like, oh, his bone's broken, but you can't say that. You suspect a fracture. So silly.
There's no step in broken.
Yeah, it's definitely broken. I put my last paycheck that it's broken. All right, so if their breathing is not adequate, then you want to provide artificial ventilation. We learned how to do this already, right? We have our BVMs. We know how to BVM somebody. We're going to go over it even more next Saturday. So make sure, or this Saturday. I guess it's this Saturday already. Provide supplemental oxygen to your patients to maintain that oxygen saturation of 95 to 99%, because we can't read if we give them more than 100% oxygen, right? So try to aim for those numbers. If you're bagging somebody and they're not breathing at all, don't be like, oh, they hit 100% and then stop breathing for them and then breathe for them again. Don't do that. Just try to aim for these numbers. It's okay if you hit 100%. Nobody's going to be like, you better stop breathing for them. Nobody's going to do that. So we're always constantly, words are hard today. We are constantly assessing our patients, right? So remember, we were talking about if they have respiratory failure or airway problems or impending airway problems. So if you are suspicious that this patient is going to lose their airway, you need to consistently assess your patient and then intervene whenever you see those signs, right? So our positive pressure ventilation. I put this picture up here specifically. What's this guy doing wrong?
The way he's holding the mask.
Yeah, the way he's holding the mask. Is he lifting a chin?
No.
No, he's not. I've seen this.
I can tell you
Yeah,
right
I
now,
know.
he's about to introduce a lot of air into this guy, tum-tum, the way he's holding that BVM.
Yes. So how do we correct his actions? This is Billy Bob, the volunteer firefighter.
Take away.
Yeah, like, hey, ding, ding, stop that.
Just kick him in the face. No, don't do that. Say, hey, buddy, lift the chin up. Let's open the airway. I've had plenty of first responders, people that I've worked with, who are working at cardiac arrest, or somebody that needs bagged, and I'm watching them shove their chin down into their chest. I'm like, let's open that airway. I don't want to deal with puke today. So gently remind somebody if they take offense to it, frick them. But yeah. So we use positive pressure ventilation whenever somebody has completely stopped breathing, right? Or if their ventilation is not adequate. So if they're breathing at a rate of 39, 38 times a minute, and they're taking really shallow breaths, and let's say that they have like foam coming out of their mouth, like a flash pulmonary edema situation, and they don't meet criteria for a CPAP, and it is okay to bag somebody while they're looking at you. That freaked me out when I first started this because my partner was like, bag them. And I was like, he's looking at me. We're talking. I shouldn't be doing this. But just know if somebody is in that respiratory failure part of that little ladder, a lot of times if they can't take a CPAP, then you're going to have to bag them. So just breathe with them whenever you're bagging somebody that's alive, awake, looking at you. Try to time your ventilations with theirs. Okay. Yes.
I got this question wrong on the test.
Mm-hmm.
It said someone's hyperventilating. And then one answer was breathe the same with them, or
Breathe against them.
yeah, breathe against them.
So as they breathe out, you're.
But I got it wrong because I was thinking it's like if someone's hyperventilating, you're sitting there breathing, like helping them hyperventilate pretty much.
Mm-hmm.
Aren't you doing the opposite of what you want to do because it's causing their artery or whatever to dilate, and then they're not getting oxygen anyways?
If you're putting too much. So, yeah. I would say, I think I'd have to see the question because this is also situation dependent. If you have someone that's like Kuzma respirations because their blood sugar is too high, that's a metabolic thing. They're breathing like that to compensate. Like that's good. You want them to breathe like that, right? Whereas like you have somebody that's like hyperventilating really shallow breaths, you're still breathing at a rate of 5 to 6, but you're trying to time it each one of your breaths with theirs. Does that make sense? That kind of answer?
Sometimes when people breathe fast, they're doing it for a reason. And so like when we stick tubes down people's throats and we put them on a vent, sometimes we'll jack their respiratory rate up real high, like even up to like 25, 30 times a minute to compensate with them. Because if we take away their compensatory mechanisms, we're just going to kill the crap out of them because their body's compensating for something. And so as we're breathing for them, we're trying to help compensate their body with them. So there are instances where you have to breathe with that patient when they're breathing real fast like that. But
And then when
is
they're
that the question?
Grab it right now.
Yeah, pull up the question.
Yeah.
So when they're breathing slowly, because that was like later on in the chapter, when they're breathing slowly, it says add ventilation in between patients only to increase their rate.
Yeah, because I don't personally know of an instance where your body would compensate by breathing super slow. So you're going to need to breathe that extra for them. Your body will raise breath rates to compensate, but it won't lower breath rates to compensate. Does that make sense? So when their body's starting to like shut down, it'll slow their respiratory rate super, super low. And so that's when you need to get those extra breaths to help reoxygenate their body. But on the flip side, when they're breathing really fast, sometimes you have to breathe fast with them to help their body compensate. If that makes sense.
Yeah.
Bodies are weird.
It said for a patient with rapid ventilation, you should, and then I pick increase the volume of the breath that I would deliver for them, right? Like if they're still breathing really fast, I'm not just gonna, and then the one that says is deliver ventilation at the same time as the patient. I picked this one.
Yeah, because at the end of the day, so that's a very vague question. It's kind of weird to answer it, right? Because like if you're breathing really fast because you have anxiety and I'm trying to breathe for you, right? Like, are you going to help much by being like, oh, you're anxious? It's a very vague question and it's odd. But I think what that's kind of pointing you at is that compensatory breathing, right? So like Kuzma's respiration, somebody that has been on a meth bender for multiple days and they're body's all hyped up and worked up and their body's acidotic, right? They're going to breathe really fast to try to compensate for that. And so if you don't ventilate
Yeah. Alright, it's not.
Did you guys say the night? Mm-hmm. Yeah, we stay the night one night. I was like, the weekend. So it's not the same. We did go by two. That's fun.
What's the? Yeah. To open it.
Please don't cut the rings.
Well, so we're gonna go the handle.
Okay.
Once you get it, it's great my challenge. It's $400.
Don't use the air fryer, like the milk plates.
No, not burning.
God, freaking- All right, they're back. I would be careful if you're anywhere over here. She played volleyball. She didn't play softball.
Okay. All right, everybody back.
We do.
They may have lost the internet. Okay. So positive pressure ventilation is the opposite. So instead of negative pressure, they're going here, blowing into just like that. So if we're giving somebody positive pressure ventilation, we need to be mindful because we're putting more pressure inside of their chest. So what that does is it inflates the lungs and adds more pressure, and it pushes down on their inferior vena cava. So it can cause somebody's blood pressure to drop, right? So that's one big effect. Another one, gastric air. Don't put it in their belly. They will vomit on you, and it sucks. Because it's not just like vomit. It's like vomit. It's freaking projectile. I have seen it hit the roof of an ambulance. Another thing, if we hyperventilate in a roundabout way because we're breathing off CO2, so if you don't breathe, that CO2 builds up. If you breathe too fast, that CO2 comes down. A byproduct of a decrease in carbon dioxide is vasoconstriction. So whenever we hyperventilate for somebody, if they have something going on, like a heart attack, we're trying to vasodilate because we want that blood to get around whatever clot is in their heart. Whereas if you are hyperventilating them, now they're vasoconstricting, so you're just working against yourself. So hyperventilation, there's one instance that I can think of where you purposefully hyperventilate your patient, and that is in head injuries. And you're not even just like, it's just a slight hyperventilation. So this is kind of a diagram. The increase, so your inferior vena cava runs out of your heart here. So that extra buildup in your chest cavity puts pressure on that vena cava, and it can cause their blood pressure to go down. So not so much like if you're bagging somebody, you can kind of see it, but whenever we start talking about putting somebody on a CPAP, which you guys can do now, they used to not let y'all do that, but they changed it. That's a big one. You don't put somebody on CPAP if their blood pressure's low because you can tank their blood pressure. Yeah.
Is the Venturi thing the same as the CPAP?
No, so that's like more of a simple mask. So it's, your non-rebreather has the bag on it. The Venturi mask has like different little caps that you can put on it, but it's just a mask. It's the same kind of thing, and you can adjust the airflow. But like it's not forcing air into their face like a CPAP.
You don't really see those in that ambulance very often.
Yeah,
Like they're
maybe like
mainly-
inter-facility transports.
Yeah, they're like mainly in the hospital. We don't really use them.
All right, so types of positive pressure ventilation, mouth to mask. Yuck.
Yeah. Don't do it.
Yeah.
Gross.
We have 2 rescuer PVM, which is the preferred, right? We prefer to have 2 rescuers, one person holding the mask like she is here, and then one person bagging like he is. What is wrong with this picture? I put these in here on purpose. Talk about it.
That's
Oh, I think she is.
They
They're just
are,
yellow.
yeah.
They're just yellow. Yeah, they're yellow.
There's definitely no eye protection. And they're squeezing the whole bag.
Yeah.
Yeah, they're squeezing the
That's
whole
what-
back with 2 hands.
yeah.
Knock it off. So she's holding the mask correctly. That's how you should do that. But if you are bagging, one hand
They
bag.
call it the princess squeeze,
Princess.
right? Like just back of the bag, princess squeeze.
The bag didn't deflate though.
Huh?
The bag didn't deflate all the way up.
Yes. So princess squeeze. Your BBM. I'm gonna stand in front of the camera. Your BBM has three lines, right? Or 3 sections, 2 lines. The last section. That's all you need. That's it. Don't be over here. Don't do that. Don't get free.
Yeah.
If I
That's
see you doing that, I'm gonna say something. I
that's
might not be nice about it.
legitimately what my first instructor said. He was like, just put it against your knee and just go after. Don't do that.
Yeah, please.
They're alone, it's like that.
Yeah, that's what we
Also,
call
the
it
patient
there.
wakes up like,
Yeah. So then we have our 1 rescuer BBM, so not ideal, but we'll do in a pinch, right? We have our continuous positive airway pressure machine, which is a CPAP. Do you want to go grab the CPAP? Just so we can see it?
Would a sea color help open the airway?
It can, yeah. So if you have somebody in a C collar, it kind of holds them up like that. So it can. Like I wouldn't use that like just to keep the airway open.
I was like,
But
"Cheat real bad."
yeah, you cheat. Put that thing on. We put them on whenever we intubate somebody because any kind of movement can dislodge that tube, and so we put it on to kind of reduce any kind of movement that might dislodge the tube. So you can use it. It's not completely unheard of. If somebody is actively vomiting or has vomitus in their airway, get that shit out of there before you start bagging. You don't want to shove it down into the lungs. Obviously, if you're bagging someone and they like vomit while you're bagging them, there's not a lot you can do about it. But if you can avoid it, try to avoid it. Because what does it cause?
Aspiration.
Yeah, aspiration that can lead to some nasty infections. Huh?
He was saying if they had dentures, you pull them out. It's like, no. You
No,
don't
you
pull
leave
them
them
out.
Yeah, if they're not getting in your way, you leave them in. If they're in there sliding around doing their own thing, take them.
if they're glued in, leave them. If not, pull them out.
Exactly, exactly.
I heard someone laugh over it the other day that had dentures I didn't know, they fell out, I was like.
Yeah, anyway.
I was like, hell yeah, that's funny.
So these are the CPAP masks that we use. They're called the GoPaps. They are really easy, but they're super effective, right? So, yeah, get all the junk out. So this thing comes with an albuterol hookup for it. Obviously, y'all can't use the albuterol hookup until you go to A school. Then you can use this. It has a separate little hose for it, so you can hook it up to a second oxygen source. And then you have the mask itself. These can come in different sizes. So whenever you're using one of these, just pay attention to the size that you grab, because like obviously I got a freaking noggin, so mine's not gonna fit a small. So goes in, hooks up to oxygen. You can adjust the PEEP setting on this thing. Start low and then move up. Don't start at 10. Yeah, just freaking, yeah, they're not gonna like it at all. So whenever you use these things, it's very important that you talk your patient through what's about to happen. So as you're using this, be like, hey buddy, listen, like this is gonna put a lot of air in your face. This goes on, it comes around, it clips into these, and then use the little Velcro straps on the side to tighten it. But before you do all that, just throw it over the front of it and stick it in front of their face, and just let them feel what that feeling's gonna like. If you ever forget what this thing's supposed to be on, it says right there, 10 liters per minute, right? But let them know what it's gonna feel like. Stick it in front of their face. Just hold it against their face for a second. Talk them through the breathing. Let them breathe through it for a minute or two, and then strap it to them. Don't just go in there and freaking wide open and be like, yeah, because they're not gonna like it. This is not fun. It's not be like, stop moving. I'm trying to help you. Yeah, don't do that. But whenever you can use the albuterol thing, it just pops into the bottom of this, and it has a secondary oxygen source that you hook it up to. These things work fantastic. You can get a lot accomplished with one of these things. So
They put it in y'all's scope of practice in these for a reason. This device here has prevented a lot of patients from needing to be intubated. We're like, this is great, it's working really well. Let's have our EMTs do it, because if you can bridge that gap of like, because if you intubate somebody that's like a bad asthmatic or bad COPD, the chances of them getting weaned off of the vent is a whole process. It takes a long time.
epoxy grabbing her.
That's why I kept that thing on me, because I knew some movie. That's a whole other thing. Okay, so CPAP. That's the device that we use. That's called a GoPAP. If you are working for a different agency that carries something different, become familiar with it. It is in your scope of practice to put somebody on a CPAP. I've also seen paramedics and advanced EMTs and EMTs put this on somebody when somebody's blood pressure was low, and they're sitting there holding the wall at the ER, because in Atlanta we'd hold the wall when they didn't have any beds available, and their patient's dead as crap with their CPAP on. It's going to make your blood pressure go lower. So monitor your patient whenever you put somebody on this. So inclusion criteria as to why you'd put somebody on CPAP. So if their respiratory rate, they need 2 or more of these. Okay, so the respiratory rate's greater than 25. You're counting their respirations, they're greater than 25. Their oxygen saturation is less than 94%. So if they had a high respiratory rate and a low oxygen sat, they'd get it, right? Now let's say that they had low oxygen sat, and you can see those intercostal muscle use. That is also criteria to be put on a CPAP, right? So these are all the reasons that I would put somebody on CPAP. Their respiratory rate's high, their pulse ox is low, you see those retractions or their intercostal muscle use. That's they win a CPAP. They get it. It's their door prize. Now, exclusion or your contraindications, right? So that the reason you would not put somebody on CPAP. Say they fit 2 of these and you're like, okay, but do they have any of these? So if they're unable to follow commands, you might see some protocols that just say altered mental status is a exclusion criteria for the CPAP. In my mind, that is bullcrap, because altered mental status is an umbrella term. Some of these patients have been working so hard to breathe and they're tired, so they're kind of doing this, but you talk to them and they'll look at you and they'll answer your questions and follow your commands. So I put inability to follow commands. You might see just altered mental status, but that's my spiel about altered mental status. It's such an umbrella term. You can have Meemaw that has dementia and never knows what year it is. That's altered mental status. Would I still put her on a CPAP if she's following my commands? Absolutely. If they're not breathing at all, this is not going to fix them. So if they're not breathing at all, it works with them and their respirations. So they need to be breathing spontaneously. Vomiting or GI bleed. You don't want to be shoving air in somebody's face and then they're actively vomiting and then it just gets shoved back down to their lungs. Same thing with the GI bleed. It can cause that stomach distension, so you don't want to exacerbate a GI bleed. So known GI bleed, usually you don't see those, but you can always ask your patient, like, have you been pooping or puking blood lately? Okay. And then major trauma, if they have any major trauma, especially to their face or their chest, that's kind of where the pneumothorax comes into play. These two kind of go hand in hand. So if you're suspicious of like an impending pneumothorax or a hemothorax or major trauma to any of this, don't put them on CPAP. If someone's having a really hard time breathing and they just got in an accident and thrown out of a car, it's probably other things going on, right? And then their systolic blood pressure. So their top number of their blood pressure, if it's less than 100, you need to not put them on CPAP. We spoke it into existence. Have fun.
If I put them on CPAP, I'll call them.
We'll all be over there.
Yeah, be like, oh, so this is our CPAP.
It's like 15 of us in the room.
Yeah, it wouldn't be the first time. One of these times last year, our class got lucky because we like landed a helicopter. We were doing a transfer, so our whole class was able to go out and like tour the helicopter while we were getting the patient. So if that happens again, we'll definitely let y'all look at it. Okay, so CPAP. If you think that they need CPAP or some kind of positive pressure ventilation, and they fit some of this exclusion criteria, what do? You bag them. So CPAP is different than bagging because CPAP's just constant. It's different. So I think the sleep apnea CPAPs don't have as high of pressures as we use. I think the PEEP on that's lower, and then theirs has all like the little internal device that tells you how well somebody slept and all that. This isn't that fancy. Those are way more fancy. This is just shove it on their face and go. So it's same idea though, just allowing air to keep going in as they take a breath. So Austin needs a quick break to go to the bathroom. So if y'all want another break, we can do that. Continuous positive airway pressure. So it's like sticking your head out of a car window. I wish he would have left the CPAP mask in here because those masks are way better than the ones that come with these. It works really good. I wish that they would make all masks like this because they're sealed in my house.
Danny's got like all these candles lit in the house. Because the power's out at our house.
This is that end-tidal monitor I was telling you about. So that's the one that goes like on the end of a tube. There's also one that's just a like nasal cannula looking thing.
That's the one that's like on the channel, it's got like a little thing at the bottom.
Yeah, it's not like the weird looking.
What comes out of that? Like, does something actually come out of it?
So oxygen can come out of it, but it doesn't come out of the little weird looking disc part. What that does is as they like breathe out, it measures their CO2 and it goes back through that tubing. It's the same tubing.
On the monitor, that's what the other one is.
I think it's purple on their
I
monitors.
think it is.
Yeah, it like.
I was trying to figure it out for a minute. And I was like, I'm not sure what it is. And then when we moved in, I was like, oh.
Right.
It's so crazy to me that like basic EMTs can't do albuterol treatments, because like I have asthma. I can give myself an albuterol treatment at home, but I can't give someone in the back of an ambulance an albuterol treatment. Like, it's so weird to me.
And honestly, like, it's weird how it's set up because, like, albuterol wise, you guys can't give albuterol. It's so severe to give. But, like, you guys have less contraindications to nitro than I do as a nurse. Like, you guys are like, okay, yep, it's their own, their blood pressure is good. They haven't taken this med. Here you go. I have to, like, do a whole nother checklist.
Oh my gosh.
Kind of crazy.
So
Here's
weird.
Oh, yeah, that's.
And here's a pediatric one.
And this, the oxygen comes through this, right?
Yeah, so right here, there's a little slit. So oxygen actually doesn't come out the nose holes like it would on a normal nasal cannula. See these little holes right here? And on that one, I think it's just got like a slit.
Oh, it does, yeah. Okay.
And that's where that oxygen comes out. So this is a
Ah.
pediatric
I always thought it
one.
came out of the nose thing.
On normal nasal cannulas, they do, but just
Oh.
on those ones, they're different.
I always wondered, because like some patients would have one with a little thing and some patients don't.
You said
Yeah.
this is a pediatric one?
Mm-hmm.
Yeah, it's a wee baby.
I've never seen it.
Okay, so there's some tubes going around. So the ones with the little orange that you guys have here, that's the adult one. So that's where we measure the end tidal. That one we stick on the end of a tube. So like if someone has an eye gel in or an ET tube, that one that he's got back there fits right in between the BBM and the tube. So if someone is spontaneously breathing and they're sitting there chatting with me and I need to know their end tidal, I'll put them on one of these nasal cannula ones. The little, so the green part goes into the oxygen. Anything that's green usually is like tells you oxygen. And then the part that like sticks down around their mouth, that's actually measuring their exhaled CO2. Yep. And so that's the pediatric one. It's just a little
So does
tiny
it
guy.
turn color?
These ones do not. So the ones that you're talking about, they're like the one-time use
Yeah.
little foam pad looking things. I don't know if I have
Breathe out too
those.
much CO, it would turn a different color.
Yeah, so it'll either turn like a tan color, yellow, or purple. So purple means poor, yellow is yes, and then tan is think about it. That's how I remember. So the thing about those, the nasal cannula, they're called side stream end titles. So the nasal cannula and tidal monitors, they can only go up to 4. You can turn them up however high you want to, but they can only physically push out 4 liters a minute. So whenever you put somebody on one of those, the highest amount of oxygen they're actually going to get is 4 liters per minute. If you look closely at like the little nose tip, there's little prongs. Those don't give oxygen. Little mouth thing doesn't give oxygen. There's actually another little hidden slit or like holes in it. That's where their oxygen is actually delivered. So the other prongs are actually just measuring the CO2. So I'll pass around a normal nasal cannula. This one doesn't This one doesn't measure CO2. Thank you. So this one that's normal, the oxygen actually comes out the little nose holes. So I'll pass this one around too. Bless you.
Holy crap.
That was an aggressive sneeze. Exactly.
Oh, there it is. Oh, okay.
And then I'll pass this one around too. This is our non-rebreather. So we'll talk about all this stuff, but so you guys can put your hands on it. Non-rebreather. I don't have a Venturi mask or a simple mask. Pretty much your Venturi mask or your simple mask don't have this bag. I'm not going to be able to pull it off this one. They don't have this bag. They're just like masks. So I'll pass this around too.
Kim sent me that text.
Oh, my internet? All of the above.
I think their internet. I'll ask her.
I always have power.
I would also pass it on. Yeah, I don't have to worry about to do that.
XRP just sounded crazy. It's skyrocketed.
What's wrong? He's sad because you didn't sit by him. I'll sit by you
Yeah.
Thursday.
So are you trading right now?
No, I'm not trading. I did XRP to check the $9 for like.
So now you're just getting money there, not have
For a
pressure.
year.
So now you're gonna be a millionaire. Now you're gonna be a millionaire over time.
Goes sick.
If you ever have to work again.
If it gets over, it's like $15, I'll have $700,000.
We're back.
No. she'll send me-
What?
What? I mean,
You know what sucks is back when, what's that one?
yeah, that's what Dad said.
When it first came out, I had the opportunity to put $1,000. Shit,
Huh?
yeah. Would have been worth over
So is it?
5.
When you